get the left lungs. Because the lungs, the airways come off like this, so the catheter goes into the right lung. That's why more than 80% of pneumonias are in the left lung. If you use the cough assist through the upper airway, or even through a trach tube, it's not going to preferentially clear the right side, it clears both sides, which is one of the great reasons why the cough assist is so effective in preventing pneumonia and respiratory failure. So suctioning, you should never suction deeply into the airways. You can suction a trach tube, or you can suction the mouth. But don't think that you're going to get anything by suctioning into the lungs, because all you're going to do is stimulate airway secretions and tear the mucous membranes. And don't even think about oxygen therapy until you try to normalize the oxygen saturation by normalizing the ventilation and helping somebody cough out their airway secretions. If patients with neuromuscular disease go to the hospital, to the doctor, and they're sent home on oxygen, they come back sooner in respiratory failure than if you do nothing for them. And if you treat them, they have more hospitalizations and pneumonias than, you know, those people who are on for over 60 years haven't had a single respiratory hospitalization in over half a decade, half a century. None of them. And our Duchenne patients and Netherlands patients, it's less than once every 10 years, much less. SMA1 patients. They have, after the age of 4, when they can cooperate with the cough assist. Hospitalizations for respiratory problems every 10 years. We published this in 1998, but again, in a system where you're only compensated for doing invasive procedures, nobody really pays much attention to this. Next. This is also in this paper that said that the non-invasively managed patients have fewer hospitalizations than pneumonias. Next. And what's so bad about giving oxygen? Well, as I mentioned, it turns off your breathing, so your carbon dioxide goes up. But also, it makes the oximeter useless. I told you, if you're sick, you put the oximeter on, you keep it on all day, and you do not let the oxygen saturation go below 95% or stay below 95%. You help the person cough out the secretions to get that saturation back to normal, otherwise you do need to go to the hospital because you probably do have pneumonia. But if you give oxygen, even to FiO2 of 25%, even 1 liter a minute, then you can be filling up with airway secretions and your saturation still be normal. And this is the main reason why everybody else fails to extubate people who are unweanable, and we virtually always succeed. Because we normalize the saturation before we extubate the patient. And we extubate the patients to continuous full ventilatory support, but it's not invasive. It's nasal ventilation, for example. I mean, this is not rocket science, and I know that you understand what I'm saying. But if I explain this to a bunch of intensivists, first of all, they'll never come to the lectures because it's not something that they're motivated to learn. It's something new that they have to learn, it'd be extra trouble for them, and there is no code to charge for, unfortunately. Next. So as I mentioned, the PFTs are essentially worthless for people with neuromuscular disease. Next. Okay, so what's so bad about a trach tube? Now, a trach tube is a foreign body. It's in your airway. You can never sterilize it. Anybody with a trach tube has as much pathogenic bacterial contamination in their lungs as anybody with acute pneumonia. And no antibiotic can clear a trach tube. You probably have Pseudomonas, you probably have MRSA. You're going to have pathogenic bacteria. There's no question about that. Now, you're colonized with it. It doesn't necessarily mean you're going to get a lot of infections from it. But you're more likely to get an infection. You know, in the hospitals, we say that in intensive care, you can get ventilator-associated pneumonias. Well, if you put a ventilator on that table, I'm not going to get pneumonia from it. If you ventilate me through a nose piece, I'm not going to get pneumonia from it. But if you stick an invasive tube in my neck and ventilate me through it, yeah, I can get pneumonia from it. It's not the ventilator that's causing the pneumonia, it's the invasive interface, okay? You cannot sterilize these with any antibiotics. Understand that. Next. 17 to 65% of patients develop tracheal stenosis. And that's the closure of the trachea. When this happens, we cannot remove the trachea. And this happens in 17 to 65% of patients. Next. As I mentioned, they have all that bacteria. Next. And people on trach ventilation around the clock tend to be hyperventilated. Now, we don't really know why, but we think it's because they're bypassing upper airway sensation. So they keep asking for more air and their CO2s go down. Now, when the CO2s go down and they're being hyperventilated, If you disconnect them, they're immediately short of breath because their brain has gotten used to hyperventilation. Okay, their kidneys are retaining bicarbonate, etc., etc. But the point is that if you're not quite strong enough to breathe with a normal carbon dioxide, you certainly can't breathe with a carbon dioxide half of normal because of chronic hyperventilation. When we take the trach tubes out, the CO2s come up to normal, and many patients who are 24-hour vent dependent are now free of the ventilator all during the daytime. Next. And invasive ventilation causes the diaphragm to wither away. Now I'm talking about invasive ventilation 24 hours a day. I doubt that this happens. It can happen in just a matter of a couple of hours, but if you're breathing on your own all day and you're just using the vent at night, it probably does not happen. Next. And of course, you can die from fistulas, connections between the trachea and the esophagus, from mucus plugging. You can die from acute hemorrhage, where the tip of the trach tube goes through the innominate artery. The cuff on the trach destroys the trachea itself. That's called tracheectasis and tracheomalacia. Eventually, the trachea can burst, and people can die from that. Infections, and so on. None of this can happen on non-invasive ventilation. Next. Survival with the trach in ALS patients is about 7 years. And that's how I know. And 4 out of 5 people die from complications of the trach. Now, none of my other patients have trach tubes, so I have no data for people with SMA or Nemelin or muscular dystrophy. But none of them ever need trach tubes, so that's why I don't have any data on this. But I know in ALS that 4 out of 5 people on trach ventilation die because of the tubes. Next. Next. So understand that there are inspiratory muscles, the diaphragm mainly, your expiratory muscles, which are your muscles for coughing, and your throat muscles, your bulbar innervated muscles. Now, we can completely substitute for the function of the breathing and coughing muscles by using non-invasive ventilatory support and by using assisted coughing like the cough assist. Okay, we can completely substitute for them, but we cannot do anything for the bulbar muscles. However, the bulbar muscles are needed for coughing and for protecting the airway. How come my SMA1 kids who have no bulbar muscle function do fine? Because of positioning. Now, they drool all day, but mom has them forward in the wheelchair so that they don't aspirate. And as long as they don't aspirate, they don't have any problem. You see, when they get sick, of course, they have to use the cough assist a great deal. And if they get intubated, we extubate them back to what they were doing, and we send them home. We cannot specifically substitute for the function of the bulbar muscles. But you don't need bulbar muscle function and still not need a trach tube, okay? The next. So how should everybody be evaluated at in general, people with neuromuscular disease should be seen once a year. ALS, much more frequently, but you guys don't have ALS. This is an end-tidal CO2 monitor. We sample the carbon dioxide that's in the blood from what he's exhaling at the nose. Totally painless. Next. Oximeter, of course, this is an ancient one. Next. This is a $15 peak flow meter. It's probably the last thing made in New Jersey. It was made in Cedar Grove, New Jersey. I don't even know if it's still being made there. It's probably being made in China now, as far as I know. It's been years since I checked into it. But if it's still being made in New Jersey, then I recommend that every one of you buy one of these things, because New Jersey's in big enough trouble. Next. And this is a spirometer. Now, this is a manual spirometer, not a digital spirometer. You cannot really use a digital spirometer to do what needs to be done, and I'll show you why. Next. As the vital capacity goes below 40%, the cough flows become ineffective, and you need assisted coughing. Next. Our treatment goals are, and this first one is very important, to maintain chest wall elasticity and compliance. Now, if someone's sitting in a wheelchair all day, what happens to the knees? They get contracted. You have to stretch them. The more you stretch them, the less contracted they get. But they still get somewhat contracted. What do you think happens to the lungs and the chest wall? If you don't expand them fully to their predicted inspiratory capacity, they get small, tight, and rigid. And if the lungs are small, you cannot generate a very effective cough flow, even with assistance. So it's very important to keep your lungs healthy. Now, if your vital capacity is 500 milliliters, but your predicted vital capacity should be 5,000, this means you're only expanding 10% of your lungs. Is an incentive spirometer going to help? You know, those things where you breathe in there and a little ball goes up? Of course not. because you can't go past your vital capacity on those things, and you're still not inflating 90% of your lungs. You need some way to inflate those lungs, and we call that air stacking, or you could use a cough assist on a pressure of 60 centimeters of water or so, to give a deep, deep, deep volume to the lungs to inflate them past the vital capacity. If you don't do this, the lungs shrink. Kids get pectus excavatum and so on, and the lungs don't grow. Now, I'm going to be lecturing in Hong Kong and in China next month. In fact, oh my God, it's next month. I just realized, holy smoke, it's in like 3 weeks. It just occurred to me. They sent me 4 questions that they want answered. And this is one of the questions, actually. They don't understand how to expand the lungs. You have got to expand the lungs to the predicted historic capacity, or they just get small and tight. And the cough assist can use this. The second thing is you want to optimize cough flows, and you want to maintain normal ventilation around the cough. Next. Now, you air stack with an ambu bag like this, where you hold each volume, but if the kids have bad lobar muscle function, you can't do that. So instead of actively inflating the lungs, you got to do it passively. And you do it passively by, for example, using the cough assist, or by using the ambu bag, maybe through a nose piece, but blocking the exhalation valve so the person cannot exhale until you feel resistance and the lungs are fully expanded. Next. Next. Another way to air stack is to frog breathe. Now, I know you ladies out there figured that I just wear this tie to be fashionable, to start a new fashion, but this is actually an instructional tie, because frogs do not have diaphragms. They don't have diaphragms. They breathe by using their throats. They go. Okay, now you can all learn that, and if you go into New York City and you drive there, I recommend you definitely learn how to do that, because if some car smashes into you, like a cop's car or something, and you become like paralyzed, you can't breathe, well, as long as you're conscious, you can always breathe by using your throat that way. I can breathe all day. No one has to stick a tube down my throat to ventilate my lungs if I'm totally paralyzed below the neck, okay? With Nemelin myopathy, the older patients can often learn this, but the children who have not very good lobar muscle function, generally you cannot do that. We can practice it later on for anybody who's interested to save their necks, literally, by driving in New York City. This is a patient whose vital capacity went to 0. The ability to frog breathe stayed adequate to breathe him without a ventilator all day until he was about 40. But then that went pretty much to 0 too. But his ability to air stack, he was able to put 1,600 milliliters in his lungs, even at the age of 47. His lungs were healthy because of the ability to inflate them. If kids or people do not do this, and they come to see me and I try to inflate them, it's like trying to inflate a stone. The lungs are rigid and hard. The more you practice and inflate those lungs, the looser they get, the more elastic and healthier they become. Next. You can air stack through the nose, and then we want to measure the volume. Next. Or through a lip seal. Next. You can even air stack through an oral nasal interface and hold the air with your throat. See, we call that the maximum insufflation capacity. That's the ability to air stack past your vital capacity and to keep your lungs healthy. This is a woman whose vital capacity was 900 milliliters, but could air stack up to about 3,000. This permitted her to cough effectively overnight. In fact, when our patients are on non-invasive ventilatory support and they sleep and their ventilator stops, they wake up frog breathing before they even realize that their machine is not working. That's tremendous security. You cannot do that if you have a tracheostomy tube, because the air will just simply leak out of the tube. Next. This is a patient with 0 vital capacity, has 12 frog breaths a minute, and ventilates all day long without a ventilator. Next. This is a small child with neuromuscular disease who's about to die. He was actually an example in a neurological textbook in England. A guy wrote that book who never bothered to learn how to prevent his kids from going into respiratory failure and keep the lungs healthy. And he actually put a photo of this child in there, showing that he's smiling just about before dying. Look at his lungs and his chest wall. It's extremely small, what we call a funnel-shaped chest. This child is definitely going to die within weeks or months of when this photo was taken. Next. This is our little boy, the first brother I showed you before. Next. Look at their chests. We can put over 2 liters of air into their chest today because they get these deep breaths multiple times a day. Next. Okay, the second goal is to normalize cough flows. Next. Because mucus plugging is why the lung collapses. Next. You can get this is a left lung collapsing because of a mucus plug in the left main stem bronchus. Next. That suctioning is not going to get. 90% of mortality in muscular dystrophy, and this is true for Nemelin myopathy too. 90% of mortality occurs because of the inability to cough, not because of the inability to breathe really. It's because you can't cough that you can't breathe and you get intubated, you can die. Next. So you need those 3 muscles I was telling you about. Taking a deep breath, expiratory muscles, and the bulbar muscles. Next. And we measure the assisted cough flows. So we pump the patients up with air and have them cough as we press on the belly, and we measure that assisted cough flow through the peak flow meter. So we not only measure the unassisted cough flow, we measure the assisted cough flow. And if that's high enough, you don't even need a cough assist. Next. And here, next, 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 next. All different ways of assisting the cough. Next. If you can use your head, any way of putting pressure on the belly is what counts. Next. And then we measure the assisted cough flows. Next. And look at the difference. Now the cough flows are becoming effective. If they told me to show one image that shows why you never need to trach these patients, it would be this one. Because we can get effective cough flows by doing assisted coughing one way or another. Next. Now the cough assist is wonderful because it allows you to measure flows. Now look at the cough flow. 223 liters a minute of cough flow. And we compare that to the unassisted cough flow. And this gives us a good idea of how much risk there is of developing pneumonia and respiratory failure. Next. Next. This is a 2.5-year-old who had her trach tube removed in Japan, and thanks to using the cough assist mainly. Next. Next. This fellow here would not have needed a ventilator at all during the day if we had taken out his trach tube, as I told his family that we could do. But he felt convinced that he'd be cured in 1 year if he just raised enough money. So he left his trach tube in and stayed dependent on the ventilator. But everywhere he traveled, what did he bring with him? The cough assist, okay? Because he knew that using it through the trach tube was far more comfortable and effective than being suctioned through a trach tube. Next. And use it at 40 to 60 through the upper airway, 60 to 70 through a tube. Next. The third goal is to maintain normal ventilation, basically around the clock. Next. How do you do that? Well, why do we do it? Who needs to use a ventilator? I'll tell you. Any child with paradoxical breathing needs to use nighttime nasal ventilation or the lungs will not grow. Now, what is paradoxical breathing? It's very simple. It's when the belly goes out and the chest sinks in. If you have a child that does not have paradoxical breathing and was put on BiPAP or nasal ventilation after having been acutely ill, the odds are that child no longer needs nighttime ventilation. But if you have a child with paradoxical breathing who's not using nighttime ventilation, or with the trach tube and is not using nighttime ventilation through the trach tube, the lungs will not grow, and the patient will develop a small chest and a pectus excavata. It's as simple as that. But what about adults or older people? See, kids can't normally complain of these symptoms, little children, but older people can. When they have fatigue, morning headaches, daytime drowsiness, increased appetite, depression, and so on, difficulty concentrating, those are signs of CO2 retention during sleep. Now, if I suspect the patient is symptomatic, I have 2 choices. I can monitor their carbon dioxide overnight, or I can simply tell them, try nasal ventilation. If it makes you feel better, use it. If it doesn't, we'll check you next year. Or we can monitor the carbon dioxide at home overnight. So that CO2 monitor, we let people use it in their homes. When they sleep at home, we give it all night. If the CO2 goes up to 48, 50 or more, then I say to the patient, look, you're really underventilating during sleep, and these symptoms are probably due to that. And if you use the nasal ventilation, you'll probably feel better, and if you don't worry about it, but just be checked out regularly. That's basically what I tell the patients. Because if you're not symptomatic, Even if your carbon dioxide is a little bit elevated, you're not going to want to use it anyway, and there's no evidence that you really need to. Okay? Next. So how do you begin? Well, I just mentioned this. Next. Really what it is like when the diaphragm gets weak, just like a weak horse, it gets fatigued. Next. And if you don't rest that horse, he's going to collapse. The same thing is true for the diaphragm. Next. So the ventilator is like a pickup truck. Next. And you know, if you use the vent overnight, your daytime carbon dioxide normalizes. And you feel better, you have more energy, and your symptoms are gone. That's really what happens. Next. Oh, don't use BiPAP. Well, unless you have absolutely no choice. Now, in third world countries like the United States has become, I tell them that BiPAP is better than nothing. And it's true. BiPAP you can use for ventilatory support. Because understand that for normal lungs, whether you're a baby or you're 80 years old or like us, we would need to get a volume of air at a pressure of 18 centimeters of water for a normal breath, or a volume of 500 milliliters, which generates a pressure of 18 centimeters of water. It doesn't matter whether you set the volume or the pressure. The difference is that if you set the volume, you can air stack, and there are certain other benefits. But if you set a pressure, that's fine. But you don't want EPAP, because if you set an EPAP of 5 and you have an IPAP of 18, you're only getting 13 boost to your inspiratory effort. That's not adequate rest for your muscles. But if you set the IPAP to 23 and the EPAP of 5, that's the same as 18 and 0. But with BiPAP, you can't turn off the EPAP. So that's why we don't use it. Now, I used to about 20, 30 years ago, but I learned better since then. Like I say, in third world countries, I tell them, get BiPAP if you can afford it. I even tell them to use your vacuum cleaners, because you can use a vacuum cleaner both for coughing, because the cough assist is a vacuum cleaner motor, and you can use the exhaust for ventilation. Believe it or not, in the 1950s, that's what people did. They came out of iron lungs, and they had the exhaust of a vacuum cleaner, basically, called a Zephyr, with a mouthpiece, and it was blowing in their face. And then they grab it, get a breath, when they've had enough air, they exhale, and then they grab it again. It wasn't cycling air, it wasn't a ventilator, it was a blower, and it kept people alive. Nowadays, the companies make these ventilators extremely complicated, not because it's necessary, but just for marketing. So they could say for the trilogy, we have 11 ventilation modes, and our competitor only has 8. Well, you don't need money, and it's not BiPAP, okay? But again, you have no choice because your insurance won't pay for it, which I have not yet heard in the United States. BiPAP is better than nothing. Next. Yeah, LTV is excellent. Next. Or a trilogy. But the trilogy has 2 BiPAP modes. If you tell me you're on an LTV, I know you're treated properly. If you tell me you're on a trilogy, then the respiratory therapists from the home care company who only know how to use BiPAP undoubtedly have you on BiPAP. And they charge more for it because the insurance companies pay more for a trilogy, which is $12,000, than a BiPAP machine, which is $2,000. So the home care companies put you on trilogies, charge for the ventilator, and use it for BiPAP settings. I'm telling you, that's what happens all over the United States. You can use a trilogy correctly, but not on BiPAP settings, okay? Next. And I mentioned the indications of paradoxical breathing or symptoms of underventilation. Next. By the way, what time is it?
It's about 12:15.
Oh, okay. Well, then I'll have to stop, but I have to show you a couple of, keep going, go off, keep going, now. Keep going, all right, keep going. All right, I want to talk a little bit about X, keep going. All right, keep going. Wait, hang on. All right, well, go back one. Go back one. All right, no, forward 2. No. What happened? Okay, this is a pneumo belt, okay? Pneumo belts are going to be back on the market. For people who need a little bit of help breathing during the day, you don't have to have anything in the nose, the mouth, or the neck. You can actually have a girdle with a bladder that is pumped against the belly and moves the diaphragm. Next. Keep going. Next. Okay, hang on. Okay, go back again. So this is a patient that was admitted on a Friday afternoon with a neck injury, no ability to breathe. She was intubated, has an NG tube. Next. She cannot pass any ventilator weaning parameters. She cannot breathe. Next. Look what it says here. You need an adequate cough, few secretions, and should be able to breathe a little for a period of time for at least 4 hours. But she can't do any of that. So I came in on Monday and we extubated her anyway. Next. We get her lungs to normal saturation when we extubate. Next, next, next. So we extubate her into nasal ventilation. Next, next. But we let her choose. We use the cough assist to clear the secretions. Next. We show her mouthpiece ventilation. Next. And lip seal. Now she just used the mouthpiece 24 hours a day. She always spoke Polish. I told her I wanted to use a lip seal. She wouldn't listen to me. But anyway, she did fine that way. Next, 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 next. All these patients have been intubated and sent to us to be extubated. In Nemelin, we've taken the trach tubes out of 2 people who were mechanically vent dependent with Nemelin. They were really dependent 24 hours a day, and after we removed their trach tubes, they weaned to nighttime ventilation. And we've had a number of Nemelin patients who were unweanable and transferred to us. In fact, one of them is here today, Amy. I know she doesn't mind my mentioning it. She come to see us for about 12 or 15 years or something. And she got a bad cold, she got a chest cold, got pneumonia, was intubated at Robert Woods Johnson Hospital. But of course, they couldn't extubate her. I think she failed. How many intubations did you fail? 1 or 2? 3. She failed 3 extubation attempts there, came to us, and we extubated her. And she went back home, back to work, and I needed to talk to her about it. Next. Oh, and this is what we did with Amy, because this is an interesting interface. She leaked too much air out of her mouth when we tried nasal ventilation. So we ventilated through a mouthpiece. Next. Oh, and there she is today. Next. Now, I know you don't mind my showing you guys, but Arthur O from Hong Kong. Arthur was intubated in Hong Kong, failed extubation attempts there, and was flown here, intubated, in a commercial airline with, I think, one doctor and a nurse. And I think we extubated him in under 24 hours. He was intubated for about 2 weeks. And he could not be extubated in Hong Kong.
He was intubated.
What's that?
He was intubated for over a month.
No, as a matter of fact, I couldn't believe it. It said that he was intubated for several months.
Yeah.
Yeah. And they just couldn't extubate him, so they flew him. Now, we've gotten people from Iceland, from Qatar, from Saudi Arabia, intubated, who refused trach tubes and got transferred to us. We extubated them all. And as for Jackson, now you know the story much better than I do with Jackson. Next slide. Well, that was off. Next. Well, anyway. There's no point in going through all this. Next. Okay, ventilation. Let me just tell you that anybody with a trach tube whose airway has not been too damaged by it, even if they're 24-hour vent dependent, can have the trach out if they want. And if they are 24-hour vent dependent, we will only do it if the person is over 12 years of age. Because if you're 24-hour vent dependent, a child would be very frightened to have their trach tube removed. But anybody who's just using nighttime ventilation, and if the trach hasn't been destroyed by the tube already, it's relatively simple to take the trach tube out. Jackson that was sort of the case with Jackson at that time. He was only 1 year old, that's true, but we were able to manage him without the vent until he got a little older. So anyhow, I guess I'll stop there. I don't know if there's no time for questions. If you want to ask any questions, you can ask me. Yes? You started what? Yeah.
So my son is 8, he is trached, he was trached at 13 months. Our pulmonologist is very supportive of non-invasive.
Oh.
We were doing it. He got very sick, he was intubated, he failed extubation 5 times.
Yeah, how do you use the cough assist? How?
Loves it. He was using that with the non-invasive, like.
And through the tube too.
Oh, he still
Good,
does, yes.
good.
Yes, he still does. The problem was that we couldn't find a mask to be supportive enough. Because if we couldn't use the mouthpiece, because he drove in no control over his secretion, so it was a risk of him aspirating.
And nasal ventilation was definitely not effective.
Pardon me?
Nasal ventilation was
No,
not
we
effective.
we could not make it work, it wasn't supportive enough. We tried, my dad tried using things and everything.
You know, I'm skeptical of that. Now, it's true on rare occasions that can happen. But There are many interfaces. First, how many did you try oral interfaces?
We tried a lot.
Which
I don't
ones?
know if we tried.
There's the Oracle, there's the lipstick.
7 years ago. Oh, we did not do the oral ones because he had.
The secretions, I understand. Yeah, no, I understand. Believe it or not, most people can do that, can tolerate it, and using oral ventilation, but I really don't, I'm not totally convinced that he couldn't use nasal ventilation. I'm just not totally convinced. I think it's possible to make a custom interface or find a custom interface.
I think it was because he was so small.
Oh, no, let me tell you. They have interfaces, we've used them, look, I told you, 20 years ago. We constructed nasal interfaces from Hudson CPAP prongs, and we put it through the foam from the nasal bridge foam of an adult CPAP mask. We constructed nasal interfaces that were effective for infants 20 years ago. And sometimes my therapists still use those, the ones that they construct themselves, instead of the ones that are on the market. See, I'm just not convinced that at the right pressures and settings, that nasal ventilation would leak too much or wouldn't work. I mean, I encourage you, if you live around here, to come in to see us, Also, I'm curious who your home care company is. What state? Oh, you're in Buffalo. Did you bring your shovel with you? Is that the time of year? Okay. Yeah.
Dr. Bach, I hate to cut you off, because there's so many good questions out there. I believe you're staying for lunch, that's the case. So hopefully we'll allow you a chance to eat as well. Someone's going to be fighting for you at their table. Now let's quickly just review. There are going to be all the clinicians and researchers from downstairs. Hopefully are completing and finishing things up, and they'll be up here. Now they have a light blue badge on the bottom of their name.